I mean, it was great to meet you at the Skokie Chamber of Commerce, and welcome
likewise.
to the show. Because when we met, I was so intrigued. I remember meeting you because you started talking about healthcare in a way that's not normal for most doctors.
Sure.
You were talking about relationships and relationship-based healthcare. And then I looked on your website, and that's what you're all about. And, you know, so much of the time, I mean, and I think I told you that my primary care doctor is a waste of time. Yeah. I'm basically my primary care doctor, and I'm just so frustrated with healthcare in so many ways in this country. And you started talking about that, and it was so intriguing. And I believe that your clinic is called Bridge Direct Care, right?
Correct.
Located in Evanston.
Yep.
And it says relationship-based healthcare. And I remember when I emailed you and I asked you, we're doing this series on incentive structures, and one of the parts of society we want to deal with is healthcare. And you said, quote, "I think, write, and speak about the misaligned incentives in healthcare a lot," which is part of what drove me to start my own practice. Yeah. So before I go into your practice, which I definitely am going to ask about, I just wanted to give our audience, if you could give our audience a bit of your background and
Sure.
What inspired you to get into healthcare to begin with.
Yeah, no, that's great. And thanks so much for having me.
Oh, sure.
So I guess starting in my childhood, my dad was a family doctor.
Okay.
Still is, but not practicing anymore. But I grew up in Pennsylvania. Okay. In a small city / small town in called Wilkes-Barre, okay, Pennsylvania, in the northeastern corner there. And I think probably subconsciously I saw the I went on house calls with my dad. I would go. About
what age?
I mean, I was young, like 6, 7, 8 years old. I remember going, and I saw him interacting with patients and him going to nursing homes and sort of following his patients, whether they were in the hospital or at home. I remember this one time one of his patients was in the ER, and he went in and sutured them up in the emergency room. And just the sort of, you can see patients, when they see somebody that they know, and I have like vivid memories of their face sort of lighting up, or at least if they were in a tough situation, at least being comforted by seeing him. And I think he worked a lot, but he sort of, his metric for like how he did his work was based off like the panel the patients that he cared for. So, nobody else in my family went into health. I have 2 brothers. They didn't go into healthcare. I didn't really think that much consciously about my dad when I was making decisions. Yeah.
I can relate to that, by the way. I mean, I went into production. My father was a television producer, so I was just like, I never really thought about it, but people are like, well, you sure?
Yeah, exactly.
Well, so what about, like, what years were you, were you going around with your father initially? Like, what year are we talking about? Because it's interesting because he seems to epitomize relationship-based healthcare.
Yeah, no, exactly. And I sort of came around to that even in recent years, thinking about, I'm really trying to do what he once had. So he was a doctor in the 80s and 90s in Pennsylvania. Okay. And then I left, Pennsylvania around in the late 90s. Okay. And ended up going to med school and did residency in the early 2000s.
You went to Northwestern?
I was in Philadelphia. I went to Temple, and I went to Jefferson for residency. Okay. I did a grad school program at Northwestern later, gotcha. But that actually formed a lot of, the things I mentioned in my email with the misaligned incentives. I got a grad school degree in quality and safety. And so there I learned a lot about systems thinking and design and certain things that you don't think a lot about.
And what years did you attend this program?
That was 2013 to 2015.
Okay, so would you characterize that type of thinking, that type of program at Northwestern as progressive, more thinking outside the conventional wisdom at the time? Were they doing things that made doctors rethink how healthcare should be practiced?
Yeah.
Oh,
Definitely.
Oh, that's very encouraging.
It's a small program. I mean, there was probably 20 of us in my graduating class.
Okay.
And it was pretty sort of focused on how do we make healthcare better.
That's a nice
Yeah.
objective.
And so it wasn't, a lot of people who are doctors who want to think about the system might get a public health degree or an MBA. And this was a little bit more focused. I took some classes with MBA students and then I took classes through the medical school. But yeah, it was pretty focused on quality measurement and designing systems and designing and human-centered design concepts like that I had never heard of.
Oh, that's
before.
terrific.
Yeah.
Well, I first wanted to tackle, in order to, the system that needs to be transformed, because there seems to be a barrage of obstacles, in our current everyday healthcare system, to having doctors really do what they went to medical school for, which is to care for patients. I mean, I heard this term a long time ago in terms of the way in which healthcare is administered, really and largely controlled by insurance companies, unfortunately. I mean, the term medical mafia comes to mind because it takes advantage of people at their most vulnerable state, which seems to make sense. However, everybody has different views of that, but it seems to be about, and I think I talked to you about this benefits program, pharmaceutical benefits program, when we met at the Skokie Chamber of Commerce, but it seems like the health insurance companies are managing, they have this term managed care, and it seems like they're managing profits, not really managing people's health care and wellness. So I'm wondering, before we go into the things that you do in your clinic, what are some of the obstacles that get in the way of doctors really practicing medicine in the way that's most helpful to the patients?
Yeah, that's a good question. And it's such a complex system. And I think that probably the frame that I think a lot about is based off of a thinker and leader in the healthcare space called Don Berwick. His name's Don Berwick.
Okay.
He founded the Institute for Healthcare Improvement and was the head administrator at Medicare and Medicaid during the Obama years for a year. And he also him and his organization came up with the idea of the triple aim, which anyway, he's a knight in the British in Britain too, because he's a renowned figure.
Oh, okay.
He wrote an article called Era 3, and I think it was called that. It's something about the first and second eras of healthcare and how we need to move beyond them. And so I think it's worth explaining because it's a framework that I think a lot about.
Please.
So Era 1 was the era of my dad. The professional, the physician was sort of empowered and entrusted by society to do the right thing for their patients. And it worked well in some ways. And then in around 2000, around the turn of the century, there was a few reports put out by the Institute of Medicine that basically said healthcare is not as safe as we thought it was, and we're causing harm to people, medical errors and whatnot, and then it's not as high quality as we thought it was. And so not everybody had access to somebody like my dad, so it wasn't equitable necessarily. And we didn't have measurement. We weren't really measuring. A doctor might thought they were doing well, but they weren't necessarily, they didn't know, did their treatment work or not. So we had to move. Healthcare had to shift into the era of measurement and accountability in some ways, or I shouldn't say it that way. There was reasons to shift from this idea where the doctor knows what's best to how can we actually know that we're doing our patients, doing good for our patients, doing well by our patients.
My radar is up.
Yeah.
I'm very concerned about where you're going with this.
So then Era 2 came about, and I think that's where we're going to spend our time talking, like what you're sort of alluding to. And Era 2 is sort of the it shifted completely onto this other side where it's the era of sort of scrutiny and accountability and external measurement.
Which seems on its surface rational to some degree.
Seems rational to go in that direction. But when you overshoot and you have sort of minimalistic or measures that are basically not representative of what people want in their healthcare, you're not measuring whether or not you built trust with your doctor. You're measuring things that are easy to measure, like pap smears and mammograms, and whether or not you were asked whether you were, say, depression screening, those sorts of things. So you're asking you're measuring things that are easier to measure that are important.
Sure.
Nobody's going to argue against getting cancer screening on people who meet the criteria to get cancer screening, age criteria and whatnot. But that's such a small, sort of thin piece of healthcare. There's so much more. And so I think that's what's happened is you basically shifted from sort of this era where doctors and patients, there wasn't a lot getting in between doctors and patients. If you were there and you had a good therapeutic relationship, a doctor could sit there and look at you and listen, and you could build a human bond and a human interaction that allows them to better, understand what's going on with you and come to a decision about how to best support you. This day and age, there's all these electronic, medical records that have then taken this, all of these measurements and sort of forced that into the doctor-patient relationship. So when I am a doctor taking care of a patient with a medical record, I'm sort of told, maybe not directly, but indirectly, that I should be asking you all of these questions. And it sort of gets in between, the doctor and the patient and the interaction that they were having before.
Can you give us an example of something that might get in the way? And I think the term that I read in some of the articles you sent me to just get up to speed on what your perspective is on EHR, electronic health records. Is that right?
Yeah.
Okay, please.
Yeah, sorry, I know I'm using terms.
Oh no, that's quite all right.
So yeah, it's actually, and I'll give you an example, but it's interesting that I have hypothesized in some of the work that I've done and the research that we've done that the EHR, the electronic health record, and this movement, this quality movement, this movement to better measure quality and report on quality happened at around the same time, early 2000s. Okay. So you have these two things happening, and they sort of feed off each other. So there's this quality movement. Hey, we should be measuring these things. Well, then it gets put into an EMR, which then inserts itself, or an EHR, which then inserts itself into the interaction. So those two things happening simultaneously, I think, is part of the challenge. And we don't really understand we don't have a 100% full picture of what quality is in healthcare, and yet we're implementing all of these things that are parts of the puzzle. So
which what you're alluding to are, unfortunately, the impetus to do this might have been coming from a good place, but now it's getting in the way. And what are some examples where these mandated questions that you have to ask might get in the way of your, healthcare that you're providing?
I could think of a few. I went to my doctor the first time that I saw him, and I remember him asking me a series of questions, one of which was whether or not I wear sunscreen.
Okay.
And and I felt
seems rather innocuous.
Yeah, but I felt like it was, he probably had 15, 20 some questions that he was sort of going through, and it felt fine, but it felt like he was trying to get through it, and I didn't really feel like the questions were that important to me. And fast forwarding to my current practice now, where I'm in Bridge Direct Care, when I meet a patient, we sit down. They've given me a bunch of information ahead of time. I ask them, and I think the idea of filling out questionnaires, I don't think is a bad thing. I think the idea of filling out a questionnaire and then you feel like nobody's actually reading it. I feel like a lot of patients might be feeling that this day and age. They're writing down their information a lot, and where is it going? For me, I have patients do that, and I really study them and read them, and then when I meet them, we have a conversation. And instead of me asking them a series of very medical questions, my opening question is, tell me about yourself. Tell me your story.
I love that.
Like, who are you? And, you know, in those sorts of terms. And so some patients will start talking about, you know, like their adulthood. And then, you know, I then further probe later on in the interview, well, tell me about your childhood. And so really trying to get to know who this person is as a person, not only as a patient.
Yeah. Oh, that's great. Because it seems like if you're going through a checklist, it's so like subconscious where you can kind of withdraw from the interaction that's right in front of you, as opposed to being present, which is most important. And I guess in a subtle way and not so subtle way, that can take people away from being present with the other human being, which is critical for, you know, doing practicing healthcare for real in a genuine way.
Yeah. Exactly.
So you sent me, and this kind of, you're alluding to the problem with metrics, and you sent me an article that you helped to write called The Solution Shop and the Production Line, the case for a frameship for physician practices. And this is really interesting. There's a blurb here that I just wanted to read for our audience. It says, the shifting of financial resources within the U.S. healthcare system away from direct patient care, particularly non-procedural care, and toward technology companies, data aggregators, insurance, and pharmaceutical providers, and performance measurement subcontractors reduces the funds available to physician practices to support the team structure, stability, and skill levels needed to manage the majority of the production line work. Thus, as performance measurement has grown, which is what you're alluding to, billing has become more complex, and third-party entities such as insurance companies and commercial pharmacies have automated their processes at the expense of clinical practices. Physicians have been tasked with a growing volume of production line work. This really struck me. It said the tension between these two poles contributes to moral distress and burnout. Could you speak to that a little bit? Because that's really, really intense. And, you know, you were talking about these two forces coming together, like we want to have healthcare better, which seems like a great initiative. And now to quantify it and to measure it seems like a rational thing to do, but unfortunately, it's actually been detrimental to the practice of healthcare. Could you speak to that a little bit?
Yeah, I think that there's a few things in there. There's the bureaucracy that has formed. There is this creation of a lot of middle men or middle persons, gender neutral there.
Middle people.
That
not little people, middle people.
That you know, that in some ways were inserted at some point to help with some piece of the puzzle, but have at this point are creating a lot of what I think is unnecessary bureaucracy. And so they're, and it has to do with, in some ways, the way that we pay for healthcare, and in other ways, just the way that, you know, quality and performance measurement was instituted. And so, you know, there's a lot in that passage that has to do with like payment and insurance companies, but there's some of it that just has to do with performance measurement. And I think that what me and Dr. Sinsky meant when we talked about that sort of the production line and the solution shop.
Did he help write this?
She.
Forgive me.
Yeah, we co-wrote it. We had sort of toyed with some of these ideas for a while, both of us individually and then together over the course of maybe a few years, and then this came together. We both have a shared interest in this idea, but the idea that the production line, which is, let's say, the things that we know we want our population to do. I mentioned cancer screening before. There are, you know, a bunch of other measures of, like, for example, a diabetic should get a foot exam and should get an eye exam and should get, you know, annually, basically, and should have other testing. And then there's other people with chronic disease who have a list of things that they should get.
Okay.
And making sure that you do all of those things in the middle of a human interaction, sometimes you're multitasking in a way that can be overwhelming and can hurt the human interaction. Those examples I gave were actually ones that most clinicians would agree should be done. But then there's a whole host of other things that, for example, assessing somebody's preferred learning style. That's actually something in electronic medical records where you're supposed to, and it's well-meaning. Like if a patient doesn't understand what it is that you're trying to communicate to them in whatever format, how are they going to be empowered or engaged in their own healthcare? But when it becomes a measure that you have to check in an EMR, it can become forced. It can become, like, oh, what's your learning style? And this happened to me. I was actually in a room. So I had the situation where I was happened to be in the room with a medical assistant when she was rooming the patient at the beginning of the visit, and this is, probably about 5 years ago, because at the start of the day, I wanted to jumpstart my day, so I just sort of sat in the corner, let the medical assistant do her thing with the patient. But she was asking this series of questions, like did some questions to assess for depression and anxiety, and then asked the patient, "What's your preferred learning style?" And the patient sort of looked at her with a confused look and said, "What?" And she said, like, "How do you like to learn?" And the patient's like, "I don't know." And she's like, "Are you a visual learner? Are you a verbal learner? Do you learn by experience?" And I mean, it went back and forth several times. And then finally, the medical assistant sort of pinned down the patient and had an answer that she could put into the medical record. Not that we did anything with that information. We didn't, we don't have the systems in place to create, catered learning materials for a certain type of learner versus another type of learner. So it was really literally just to check a box that she was told to check.
And that's really the issue about checking boxes, as opposed to, it seems to be well-meaning. And if, I think the healthcare practitioner, whether that be the doctor or the assistant, they should have the latitude to realize that it's not going anywhere and we don't need to check the box. And it might be helpful, but it's not that helpful. What are you talking about? Do I learn better like swinging from the ceiling? I don't know. What are you talking about? And then she's giving examples and the person's still confused. And now there's tension. And now anxiety might be ramping up and say, am I not answering the question? I don't understand what you're saying. And then all of a sudden, they feel like they're not knowing what to do, and then there's distance. And what's interesting is the distance that happens between people can be so subtle.
Yeah.
And anything, and when you were talking about these checklists that you got to get through, anything that for instance, when I would teach people how to interview at Northwestern's journalism school, I would say, don't ever, people often will say, will this be edited? You just say, absolutely. Don't ever laugh. Don't ever joke and say, oh, of course, we'll definitely, or anything like that. Why? Because if they feel at all slighted in any way, even if it's slight, they might withdraw. Yeah. And that slight withdrawal might cost you later in the interview some gold that they would have given you. But all of a sudden, they're a little bit more withdrawn. So now you got to work against that and around that to get them to be present again with you and to trust you. And these things can be subtle, but yet be costly. So that's what came to mind when you were talking.
Yeah, I mean, and as you're talking, I'm thinking of a few things, and I hadn't really thought about this before you said what you were saying. After the medical assistant left, the patient sort of looked at me and said, can we now get on with why I'm here today?
Totally. Exactly.
And it's fascinating because it's the opportunity cost, that you spend this time talking about these things that we don't really care about. We care theoretically their preferred learning style, but we're not using that information. So we don't really care about it in the short term. We're not doing anything with that information, and the patient doesn't care. And so we're spending time. And I think you're right. The medical assistant, who our medical assistants are extremely talented and and could add a lot to encounters. And since that time, 5 years ago, we really shifted to say, you know what? Ask the patient why they're here. Get to know them. Build a rapport. Like that's the human side. That's the sort of helping more with the solution shop that we talked about in our article. And I think that this idea that there's a bunch of things that we have to get through, most of which are, all of which are well-meaning, some of which are valuable, and some of which are maybe waste, you know, at this current juncture, that all of that stuff competes with this human interaction and this rapport building, and they don't, it doesn't have to be that way.
And who's mandating? Is that directly from the insurance companies? Is that how it's rolling out, or?
Yeah, I think that this is why it's complicated, is it's not, some of it is a misinterpretation of a regulation. So for example, or an old metric that was put in place that is no longer, required, but it was put in place. So who mandated it is a good question. There are, just to give an example, there is something called a patient-centered medical home. Have you ever heard of the term?
Say that again?
Patient-centered medical home.
Okay, no, I've not.
So basically, the patient-centered medical home was initially a theoretical construct, and it became a set of measures. And that's actually the interesting, where I think it ran into some trouble. And so primary care, I'm going to go backwards.
Sure, please.
Before the patient-centered medical home, there was this idea of what is good primary care, and this is what I'm trying to create in my new practice. And this woman named Barbara Starfield, I think in the 1990s, came up with this concept. Good primary care is first contact. Like when you have an issue, you go to this person or this office because you reach out to them, you call them, whatever, because you have an issue. They're your first person. They're your person, or they're your team. First contact, that's the first C. Second one is comprehensive. You can go to them for anything. Even if they need to refer you on, you can bring anything to them. Third one is coordinated. Okay. So they help coordinate your care. If you go to a specialist, they're still aware, they're still involved. And fourth is continuous. So it's not a few days that they know you, but they know you over long periods of time, over years. So good primary care, I think most people that would resonate with them, those 4 C's are good primary care.
Sounds terrific, actually.
So then you move into the model of the patient-centered medical home. So it was this idea of, how do we do that in bigger practices, in health centers where I've been working for several years, where you have these larger offices with multiple providers. Well, we want to create a patient-centered medical home. We want to create within these larger offices a way that people can say, yeah, that's my doctor, that's my team. I could get in touch with them when I need it. I could continue have a continuous relationship with them. The problem was, and so I really resonated with me. I was actually the PCMH, the Patient-Centered Medical Home Physician Champion for a health center that I worked with. This is around 2012. But I found that I was being sort of told at the time, we need to make sure that we hit all of these measures. And the measures were things like, did we figure out what the patient's preferred learning style is? Did we figure out what their health literacy level is? These sort of process metrics, like measures of like the process, but the outcome that mattered was the 4 C's. And we were, and so it just became, and this is a concept that, there's a technical term. I don't know if I should use it here just because I don't want to be too technical, but
sure.
It's called surrogation.
Yes, believe me, I was going to bring up that technical term for sure. I found that fascinating. Could you just speak to that, please?
Sure. And it's
absolutely
something I've been fascinated
because this isn't just in relationship to healthcare. Yeah. This is business or whatever. Please.
Yeah, so I learned of the term. There's an article in Harvard Business Review, and they talked about sorry, I'm blanking on the company, Volkswagen, right?
Wasn't it a bank?
Wells Fargo.
That's right.
They talked about Wells Fargo and the idea that Wells Fargo, their goal was long-term relationships, customer relationships. Their measure was like, well, if we cross sell, if we have somebody who's using one of these products, let's cross sell them for another one of our products. That will help us with that. That's more of a relationship with the patient, but it backfired because there was fraud involved, et cetera.
Yeah, there's criminal activity, so they took it to another level.
But at least
Fargo. Oh my God!
And I'm not an expert. I don't know.
Yeah, it was pretty bad. Yeah, I kind of was privy to that situation when I read the article. It's like, oh yeah, but I understand. Like they got kind of over their heads, over their skis. They're like, yeah, it was like detrimental, but it seemed to be like, yeah, let's really serve the client.
Yeah, like the goal was aspirational. The goal was good, and I think that's the patient-centered medical home is exactly that. It's this great aspirational goal. And when I think about my father's practice from my childhood, he that is a patient-centered medical home. That and it
totally
that is the 4 C's of primary care. But the problem is it's hard to measure some of the important things in healthcare like trust and relationships. And one of the things that, just to give an example, in the patient-centered medical home, you do measure continuity. So you do measure how many visits do I have with my doctor this year. It's a yearly measure. So if your doctor changes every year and you see them 5 times, let's say 3 times in the year, you saw the same doctor, that was your doctor. And the next year, that person left the practice because they were burnt out or, and you switch doctors every year. Well, as a patient, and that happened 8 years in a row, you wouldn't feel like you knew your doctor that well, but they would be scoring perfectly on their patient-centered medical home measure of continuity because it's only based off that calendar year. And so it's not that measurement isn't important, but I think that
the way in which it's measured is critical. Because, this really reminds me of, how, traditional classical education is implemented in this country, which is kind of held over from the Industrial Revolution, where it's orderly and you get the grade and the evaluation. But oftentimes, teachers, and I've taught, high school, undergrad, graduate level courses, and it's so easy to get wrapped up in the grade and the metrics and did they do this and did do that, but are you really properly evaluating the student? So if they get a D on a test, but 2 days or 3 days later they really learn from their mistakes, and if they got to take it again, they would get a B or an A. Yeah. Why should they be evaluated that they got a D? What is the point of the grade? It seems like a punitive measure. Yeah. It doesn't seem to actually provide what is needed, which is to accurately represent what a student is really learning. Yeah. But like you got them at like a midway point in the learning process when they were still formulating their idea. It's kind of like taking a piano student and having them like learn a song. And then they're halfway through and you grade them and you're like, and that's it. Now we're going to move on to the next song. Yeah. And you got a D. And then like a week later, they play it flawlessly and could perform it in front of people for a live performance where people pay money. But no. Yeah. You got a bad grade because that's when we evaluated you. And it seems really counterintuitive and ridiculous. Yeah. So it seems like people get real. It's so, sorry, let me just like define this. I remember reading about surrogation. It's really the tension between metrics versus strategy. And the incentive structure seems to focus on metrics rather than strategy. So it's surrogation, just getting back to this technical term, the tendency to mentally replace strategy with metrics. Called surrogation is quite pervasive. In fact, research tells us that whenever metrics are present, people tend to surrogate, and it can destroy company value. There's a reduced accuracy of intake screening questionnaires tied to quality metrics, as you were talking about, and focusing on incentivized process measures like intake screening questionnaires leads to repetitive, and we hypothesize in your article, I believe, inaccurate completion. And something else really, really struck me, and let me just read this to you. So it kind of, gives our audience a better picture of what we're talking about. And I think this is from your article.
Yeah.
The impact on outcomes that matter, reducing mortality and morbidity from depression and anxiety, may not be as favorable as previously perceived. And ineffective screening may unintentionally detract from clinical care because care teams and patients have less time and cognitive energy to focus on other priorities during busy clinical encounters. I mean, this is like speaking directly to what you're talking about.
Yeah.
And it just really gets in the way of this human interaction, which should be the center stone for everything.
Yeah, I definitely agree. I mean, I want to go back to the education thing for a second because I think, and then go into surrogation, then into this article.
Sure, please.
When what you were saying about education made me think, yeah, the purpose of education, like I think the reason that we do education is learning, right?
Let's get clear on that. Let's
the
get
goal.
present, right?
Learning, and so we do measurement to, grading to help us on that path to learning for various reasons. But I think you're right. Your
Kind
point
of
was
see where we're at.
yeah,
which is fine.
And then to help, I mean, it could be a tool for learning. This person needs more help. Yada, yada, yada.
Right.
But it becomes punitive, and it becomes the focus really in a lot of ways.
Yeah, and also the damage that's done when a kid gets the grade.
Yeah.
And also there's authority relationship with the doctor to the patient for sure. And if the patient's picking up that the doctor's kind of like not fully there through these metrics, it can exacerbate the situation.
Yeah.
I mean, I remember, just to kind of add to that, when I took over teaching English literature and poetry and creative writing at a high school, actually in Central America, the outgoing teacher said, "Don't teach them creative writing. They're not good at this."
Yeah.
And I immediately ignored him and started a writing workshop. So instead of having them write something creative and give it back to them with a grade, I had them write. I would go outside with them when they had a draft ready. I'd read it, give them feedback, and then they go work on it and work on it and work on it and work on it. And it was unbelievable how incredible the writing was from the students. They were lit up. That like so many of this. There was one young man in particular that was so apathetic about school, and I was like, "Why is he so apathetic? I don't get it. He's really bright and everything." Well, he just wasn't inspired, and his writing was some of the best in the school.
Yeah.
I mean, it was phenomenal. All I'm saying is, if you lose sight of the real purpose of what you're doing, it's so easy to get tied down into the metrics of it and the evaluation of it and lose sight of the strategy and the actual real objective, the fundamental objective. It's so easy to do that. It's amazing.
Yeah, totally. And I think what you're getting at there, the one thing that I changed when I talk about surrogation from the article is replace the word strategy with goals, because strategy made sense in the business context.
Yes.
But I think the idea of like, what are we aiming for? What's the goal of? And I think about education all the time, in the parallel. I want I have 3 kids who are in school aged, and I want them to be learning. I feel like the teachers this day and age have a lot of sort of things that they have to keep track of, and that they're reporting back to parents. And I'm like, I would be okay if they spent less time writing an email to me and more time, use that time, focused on teaching
because it
children.
can like inhibit their intellectual curiosity. Yeah. I talk to my kids all the time about this traditional model of education that they're in, and that I'm very concerned that it is going to stunt their intellectual curiosity. Yeah. And I'm very frank with them about it. It says, don't let them do that. Don't let the system wear you down in terms of your zest to learn. And that really is a big concern for me. And the best teachers that our kids have been very aware of the paradigm that they're working on and doing their best to be flexible with it. So like you're working in a system of American healthcare, and when did you start your own practice?
This past summer.
Whoa! So this is relatively new. So okay, so let's delve into that. What were some of the main things that drove? So obviously you have a lot of issues with the conventional way healthcare is administered. So what were some of the main mantras and reasons why you started your own health? And what did you want to implement like from the beginning to transform the space and the way you practice medicine?
Yeah, I mean, I think it's a combination of things, some of which we've already been talking about. But out of residency in 2009, I moved to Ethiopia. My wife and I moved to rural Ethiopia. I was interested, and still am, in sort of healthcare as a tool for social justice, right? Like we as doctors could be on the front lines and help, not only with illness, but the things that can contribute to illness, right? So, systemic injustices, et cetera. Sure. And so being there, though, I didn't realize, I had learned I thought I was the difficulty for me in Ethiopia would be learning how to treat tropical diseases or diseases that are endemic there that aren't here, like tuberculosis and typhoid and malaria. And I learned those things. I had been taught, going back to education, to learn how to learn, in medical school, like how do you learn? And had more of a growth mindset, which is, hopefully what our children are learning these days. But I also learned about management and incentives, weirdly, and that might be a whole other conversation, the incentives in rural Ethiopia, where there were sort of single disease programs. For example, HIV is, was at catastrophic levels and hopefully is doing better these days. But so there's a lot of money in HIV, which was good. But it ended up distorting our local health center economy. We were a rural health center and we had a limited number of staff, and all of our staff always wanted to go to the HIV trainings. Okay. All of them. And I was like, but we have babies to deliver and patients to see. And, we had like 5 nurses or 6 or 7 nurses, and all of them wanted to go to each one of these trainings. And we're like, and they technically could have, from the trainer standpoint, and the trainers would pay them money when they go, so they'd get paid a per diem. So basically, and what we found out was that was basically like their monthly salary to go to this day training. So so I learned, again, this is probably a whole nother conversation we could sit down and have, but it was eye-opening when I went to one of the trainings and they handed me money, and these are, funding that comes from the U.S. and other developed nations that are well-intended, again. But I started learning about the reason why these people want to go, there's obviously a financial incentive for them to not come to work, but to go to this training. And it was hard to fight against that. And so I guess at the time I was just learning about systems, and incentives and whatnot, and human motivation. And so I think after that point, I became interested in those sorts of larger system forces, and I ended up going to grad school. I came back to the U.S. and I was working on the electronic medical record and the patient-centered medical home transition, as well as being a doctor. And I had this thought. I was like,
how long ago did you go through the Northwestern program, by the way?
2013 to 2015.
Okay, go ahead.
So, around 2010, I came back. My wife and I started having a family, and I found the contrast between Ethiopia and the U.S. Fascinating in some ways. And I can give you a few stories, but so in Ethiopia, I had extremely sick patients. I mean, it's heartbreaking, the low resources that we had. Countless people died under our watch, children, and it was, it's very sad. But also, some amazing stories of, patients would come in with tuberculosis, would be extremely skinny. They looked like they had end-stage cancer. We had the treatment for them. We would treat them. We would house them near our clinic even. It was pretty inexpensive to do that, and we had a social committee. these patients would make miraculous recoveries. Same with the malnourished children. Some of the malnourished children, we would be able to like turn them around. Their bodies look completely different within a few matter of weeks or months. And it was great to watch those successes. It was a simple system. A patient would come in. We had the pharmacy. We had a lab. We had an inpatient unit. So in order to for the things that we could treat, it was really simple, a very simple system, and you were able to pass people out. And then I came back to the U.S. and I worked in Chicago. I worked at a health center. I worked with, patients who are usually at or below the federal poverty limit. So definitely people with less means. And that was where my passion was and still is, caring for people who can't, afford the system often. Anyway, it
was simple, and when you came here, it was probably way more complicated.
And then I found myself documenting on these electronic medical records, like all of lunch and then 2 hours at night, and
just bogged down.
And I felt like the reason I was documenting wasn't actually helping patients. It was just that the templates that I had to fill out were so long. Every time I did a physical exam for an infant, I had to document like 20 points on a physical exam, just lots of boxes to fill out. And so it just didn't feel right. Like in Ethiopia, I could take a lunch break, a mental pause in the day, eat some lunch, and then, except if a baby was being delivered. But other than an emergency, which happens sometimes, but which felt fine. If there's a real need to actually help, feels good.
Oh, that's what you're there for.
Just to document all, excessively. So I think a lot of us are still feeling that this day and age, but anyway, that's what led me to go to grad school. And I did this work, I did this, got training on healthcare quality and patient safety. And I think since then I've just been trying to change the system. I had the opportunity to work at, I've moved around a little bit, but I had an opportunity to work at some organizations that at the time were sort of startup healthcare organizations that were doing things differently. And I learned a lot from working at both of those. And then I came back to the health center space 6 years ago, and we created an innovation center to try to change things. But I find that the way we get paid at health centers and in sort of a lot of you mentioned before, insurance companies or the regulators who create the measures that it's very hard to change within that system. And so
you basically have to create a new system.
And we tried to create an innovation center so that we could, like, within the bigger system, do things differently. But it's hard to do that. And
by the way, something that you mentioned in one of the articles that you sent me that struck me that you're really alluding to that didn't say specifically, which is you're a trained medical doctor.
Yeah.
And you're spending a lot of time doing things that your training isn't meant for you to do.
Yeah.
And so you're a valuable asset to the community because of your training and because of what you want to do to help people with their health. Yeah. And you're filling out these damn forms.
Yeah, no, exactly. I think the amount of time that you spend, and that goes back to insurance companies. There are a lot of, because you brought that up earlier, like doing prior authorizations or forms that you have to fill out because somebody requires them, and that so I think
somebody
whether it's like a form that a job needs in a certain format for a patient, you fill it out, or if it's an insurance company needs you to spend time talking to a doctor-to-doctor call with somebody at the insurance company to explain why your patient needs a test. That takes time. And that's what sort of Chris and I were talking about in that article. I think there's a reason, I went back to the health center space and there I thought, well, let's create an innovation center. But it is a sort of an I don't know if it's an oxymoron to innovate and operate is sort of like rubbing your belly and patting your head, because
you're pretty good at that, actually.
Because innovation is like, it's focused on experimentation and taking risks, and not with people's health, but with processes. You know, you're like, let's try this new process. And you're focused on speed and agility. And then operations is like, you want to do the same thing every time. You know, you want to you're focused on like current profit and current sustainability and not future growth. So I found, as much as we sort of talked about, let's separate this innovation center, we were still part of this larger organization that it's really hard to operate health centers these days. I mean, I love the executive team at the health center, which I'm still working there part-time.
Which one is this?
This is Tapestry
360,
Health.
right? That's right. Okay.
I mean, we have such a great team. The staff there are amazing. The executive team is amazing. The constraints on, you know, health centers, all of the things that we have to report out on, it's really hard to do innovation within it. And so now I'm getting finally to your question of like, why did I start my own practice? I think
seems pretty obvious now.
Well, a little bit about me, like convincing other people and trying to like advocate to the people that are, you know, regulating healthcare, that's a lot of work. And for me, having a space that, you know, you don't have insurance companies, you have less of the bureaucracy, and I'm able to, in a small scale with my patients, and it's just two of us, me and a care coordinator, we're able to, you know, really respond to the people in the system, you know, us as a care team and the patients, and we're able. There's really not anything else. We have to interact with pharmacies and hospitals in some ways, but it's a much more controlled system, and we're able to continuously iterate to get the process right. And so I'm constantly asking my patients for feedback, and I'm going to be working with a designer who's helping me pro bono to start interviewing my patients and really learn about. We started setting up care plans where they could interact with their own care plan, and but you know, I want to learn from them how it's working, and so you can do that sort of experimentation, again, not on medical decision making. I don't experiment on that. It's more on the like, how do we interact and how can we do that better?
So you've given yourself a whole lot of latitude there, but the question that I'm sure our audience is wondering as well as me, how the hell do you get away from the you know, the boot of the insurance companies? Yeah. So is this people pay out of pocket?
So people, so it's a monthly membership, and I think when people start hearing monthly membership, they immediately think of concierge, and they think of, you know, unattainability, like it's this extra expense, and concierge practices
unattainable for them
because it's, you know, it's like, I have my insurance, like I can't afford more, and so the model that I'm doing is called direct primary care, and it is a membership model. It is different than the sort of traditional concierge practice, which is, you know, one of two things. Either it's usually more expensive than I know of a concierge practice on the north side that is, or farther up on the North Shore, that is, I think, $300 a month. You know, for my clinic, for an individual, it's $85 a month. For a family of three, it's $200 a month. So that's one difference, is there's a price difference. It's generally more affordable across the country, the direct primary care practices. And the second thing is, concierge practices, some of them will still bill insurance. So they still have the sort of, they still have to write notes that they have to submit to an insurance company to get paid, that sort of thing. Or, you know, they bill in code, and there's all sorts of staff that you need to do that.
So your clinic doesn't deal with insurance at all? Oh, wow.
So we don't deal with insurance at all. And what it immediately appeals to are people who are in situations where they're, for example, buying their own insurance. So they are currently buying an insurance plan that covers like catastrophic or unexpected, you know, needs. Like if you got in a car accident, or if you got, you know, in a car accident and got hurt, and or if you you know, developed cancer or something like that, then you would use your insurance. But it's also paying for preventive care, such as, you know, primary care, like myself. And the way it pays for preventive care is not great. I think most people agree that paying per visit and trying to quantify what you did in that visit and then get paid. Like it doesn't work well for clinicians and doctors in their offices, and it doesn't work well for patients. And so what direct primary care does is it's sort of like, it says, it's almost takes a car insurance model and say, you know what, insurance should be like car insurance. Like you don't want to use it, but it's there when you need it, you know? And then for the rest of healthcare, let's pay for it at a monthly fee. And then my doctor doesn't have to count, is this a visit or not? We're just in touch. And just to give you an example, I had a patient recently who had texted me, and then you have just different level of access. So she texted me using a secure texting app that isn't going to buzz me in the middle of the night if the patient doesn't want me to be buzzed, you know. So there's,
and of course you got to have boundaries. You're a human being.
So you create a system so that the texting app you use will tell the patient, do you want the doctor to be awoken in the middle of the night? And they're like, oh no, they wouldn't respond to that. So it protects you from, like, you know, where you can still have a family life, but if you need to be accessed by the patient, you can. And so just to give this example of this patient, so she texted me on a Friday, and she had some symptoms in her ear, and I ended up talking to her over text, and then we talked on the phone quickly, and we decided to give it a day or two, and then it was the weekend, and she texted me, and then she said it was an urgent, so it buzzed me, and I talked to her, or I said, you know what, let's meet in the clinic at a time that was mutually convenient on a Sunday. My kids had swimming, so my wife took them there, and I went to the clinic, and I already knew this patient for a few weeks, but I had gotten to know her really well in our initial encounter. We spent like an hour and a half together. I felt like I really knew her. And so it was nice to see her again. Unfortunate circumstances because she was, having these symptoms, but I got to look in her ear and some of the other symptoms she was having. She had some facial, like, eye swelling. And we made a plan right there. And I actually had antibiotics in my clinic because direct primary care, we also, we become the middle person for meds and labs too. So we're able to get patients, patients who then get, health insurance plans or health shares that are more for catastrophe, they have to pay out of pocket for their health meds and labs. Well, we get them extremely cheap meds and labs. So I had, it was like $7 for her antibiotics, which is on the more expensive end, but it's only $7.
And then she just pays out of pocket for that?
So I don't have to accept cash. So administratively, it's just part of her electronic medical record. She already has a credit card on file, and she, I paid for the meds from the wholesale med company, and she pays me back basically at cost. And so
terrific.
It's amazing. And same thing with labs. So if this patient didn't get a lab that day, but if for my other patients who get labs, basically the labs cost, $5 for a complete blood count, $4 for a comprehensive metabolic panel, which is like your kidney, liver function, $7 for a cholesterol panel. They're really, really cheap. And it's through Quest, so it's not through, but we just get really good negotiated prices that are on my website. You can go look at the website. And
it's transparent. It's not some mystery? Because I like the mystery. Where's the mystery? Exactly. I like going to the hospital and not knowing what the hell I'm paying for. And then there's this whole, I remember when I was contemplating a surgeon when I had an issue with my back, and I just simply asked one question, like, how much would this cost? And it set off this whole like negative, anxious, horrible response from the rep. It was weird. It was so obvious that so much of healthcare is veiled in this mystery. And so that's so refreshing to hear.
And so and speaking of price, like, there's none of this phone call, this text message, this visit with her. Neither of us are worried about how much is this going to, that's all included, so there's, and then.
Because that's a huge source of anxiety for a patient. How much is this going to cost? Exactly. As opposed to, how can I get the health care that I need? And for you, you're not worried about that. It's all good. I'm here to serve you. Exactly. I'm making a decent living. I don't need to gouge the hell out of you. Exactly. I don't need to speak to, I'm not accountable for my overseers who are telling me you got 7 minutes with each patient. Exactly. And that's how it is.
Exactly. So, interesting to see how her story played out. So this is a Sunday, and then I think Monday, Tuesday, Wednesday, Thursday, at least 4 days that week, we texted. She sent me pictures, and we checked in over text. And it was interesting thinking about that. I was talking to one of my friends, and I was like, that didn't feel like work. When a patient reaches out to you who you don't even know who the patient is, it's like, okay, now I have to get to know this patient. Like if I'm on call for somebody else's patient versus a patient of mine who I'm worried about and I want to make sure that she's okay, text me a status update, that actually feels good. Like I want to know how she's doing, and so the
this is all about bringing about humanity out in people.
Exactly.
I mean, everything you're saying is precisely what my problem with traditional healthcare in this country is.
Yeah.
There's so many forces that deplete the humaneness from us, doctors included. I can tell where they're just kind of succumb to the system because it's overwhelming and so powerful and controlling. And you, thank God, you're creating a model. And I mean, were you one of the first to do this type of model?
No, not at all.
Okay.
And and one thing I'll say, and I'll close out that story, is the nice thing about all of that is, all 6 of those encounters that we had were neither her or I are measuring them and thinking about okay, how am I going to get paid for this, or how am I going to pay for this? And then also, I think this day and age, when I talk about direct primary care, people are like, yeah, but do we need primary care? I could just go to an urgent care. And I think her example, if she went to an urgent care, yeah, she could have the visit that she had with me on the Sunday, but she's not going to get those 5 days of follow-up. She's not. And the people in the urgent care actually do care. They want to, but they're not positioned to have the follow-up. Their job isn't to have the follow-up.
Exactly. So, that's a huge point.
So there's something missing in sort of eliminating good primary care from our system, where we're just like, okay, I could just go to an urgent care, and I think certainly for people with lots of chronic disease, it doesn't work. But I think even for people who don't have a lot of chronic disease, would like to have a good primary care model. But the current primary care model doesn't work for most people because, you get to see them once a year and it feels very mechanical and not very personal. So
very well said. That's exactly how I felt anytime I've seen. I mean, it's just a waste of time. I remember coming home to my wife after seeing her, and the only reason why I went there is because I needed specific meds or I needed some blood work. And every single time I would say to my wife, that was a waste of time.
It's too sad because it's too bad because the people working in it, if you're feeling like it's a waste of time, then it certainly is less motivating for the people working in it.
Totally. And people who are saying, why can't I just go to the urgent care clinic? What is the motivation behind that? As you were talking, I couldn't help think, well, they're worried about the money. They're worried about this system that is for what just in general is antithetical to their overall wellness and well-being. And so but everything you're saying is speaking directly to what I was hoping healthcare could be, which is you want the doctor to understand you. People want to be heard. People want to be understood. And healthcare is one of the most important parts of their lives where they need to be understood. Yeah. I mean, I can't tell you how many doctors, when I hurt my back and had a herniated disc and I was in pain and then it collapsed and I was in serious pain, and to have a young, arrogant doctor try to tell me something about my body that I knew, and they're saying, no, I think it's a circulation issue. And I'm like, you're not hearing me. You are not hearing me. Yeah. And she was like, and then it became defensive and all this other nonsense. And I was just like, oh my God. And of course she was completely wrong. Yeah. Completely wrong. But the point is that she's part of a system, unfortunately, that she was embodying. And it's hard to be patient with folks when you see this consistently over time and it has people withdraw. But what you're talking about is very, very inspiring, where it actually injects the humanity back in one of the most humane things that somebody can do, which is practice healthcare and medicine and be a real of service to people. And so that's the reason why I'm so interested in, in doing this series, which you are now a part of, which is looking at incentive structures. And oftentimes we're incentivizing all the wrong behavior, not all the time, but oftentimes, which are leading to detrimental outcomes. So what you're doing is you looked at these incentive structures very specifically and very analytically, and now you're realizing there's a problem with it, and you've redesigned them, and now you've started your own clinic. And A, how has it been going? And B, I think you mentioned, like you talked about in this article, the production line and solution line being in the same place. And that has really helped quite a bit. So if you could speak to that about how your clinic is going now, because you started it, how old is it? About a year old, you said? Or
I started in August, so 4 months.
Oh,
yeah.
Oh my God. It's like, this is brand new. And how's it going? What have you, what challenges have you had to deal with? And also, could you please speak to how you've gotten the production line, which is the process that you have to deal with, and the solution oriented, which is really the humaneness, how that being in one place has seemed to help.
Yeah, and I think your question earlier about am I one of the first people doing this, and how did I end up starting them? A few things were mixing in my head.
Sure.
I mean, one thing I'll say is I had one of the places I worked in the past, however many years ago, it was 2016, I think. Was an organization called Iora Health, and we were doing value-based care, meaning we were getting paid per member per month, basically. So sort of like me as an individual now, members patients are becoming members, and they're paying me a monthly membership fee, and so that way of doing primary care, I had some experience doing that.
Okay.
But it was more corporate. It was a larger organization,
Okay.
but I still had the satisfaction of, if my patient calls, we're their doctor and we'll care for them, and we don't worry about, is this a visit and how much do we code it at, to how much do we bill it? So I had the experience of working in a value-based care setting and the person who founded the organization, his name is Rishika Fernandopoul, and he started as a direct primary care doctor. So the reason I brought this up is he was probably one of the first direct primary care doctors, 15, 18 years ago. There wasn't really a field of direct primary care, but he was one of the sort of innovators. And so there's been people across the country, I don't even know the numbers, but at least 2,000 direct primary care doctors. So I have a really good friend, two good friends that I did residency with, who have been doing it one's been doing it for 3 years, one's been doing it for 6 years. And I think one of the key things in direct primary care, and it sort of gets to, you were talking about humanity, is the small business piece of it is actually an important piece of it, because I've always liked small businesses. I've always felt like the care that happens when somebody owns their own small business, and when you're a customer there, you can feel the sort of love and care that goes into the work they do. And I know that large businesses, the standardization that can happen there could be really good from a quality standpoint. But it really depends on what it is that you're creating. And so if it's healthcare, if it's primary care, the relationship matters so much. And sort of standardizing across every single interaction probably matters less. In some ways, you don't want, if I'm interacting with somebody who is 60 years old and has multiple medical illnesses and is going through a divorce, and somebody else is 30 and just had their second baby, and and I don't know, their life circumstances are really different. And so you might want to sort of standardize the way that they schedule an appointment, but the actual interaction needs to be somewhat customized to that individual.
Totally.
And so,
I mean, this is so obvious,
Yeah.
but yet we have to talk about it because it's, how things are happening are antithetical to that. So
yeah,
please.
exactly. So So I think that's part of the reason that when I was working in this other company, Iora, I sort of thought about like, God, this would be great if we could sort of have a little bit more control over our individual clinics, you know? And this direct primary care movement, I feel like it's a grassroots movement. I mean, it's hard starting your own clinic and you know, I'm in some ways I'm doing a lot of like meeting people at Chamber of Commerce events and going out and you know, like I never thought of myself as in marketing or sales, but
you are
when you
now.
start your own business, you're and in some ways it's fun because it's energizing. Talking to people and hearing their stories in healthcare like makes me more motivated that I'm, you know, on the right path. But you know, I have to learn about like, you know, getting our computer systems up, our you know, all of the insurances you need, all of that stuff. It's not minor, and it's been
Right.
You know, I've had the support of my wife. My father-in-law is basically my CFO. I joke because you know he's a finance guy, and so he's helped me out a lot. So you get like a lot of free help from your friends.
Same
and
with
family.
my wife.
Yeah, exactly.
She does that for our business. Oh, absolutely.
It's been great.
Yeah, I mean, well, I wanted to also mention, you know, like, I wanted you to touch on, you know, the solution shop between the production line, and you mentioned, I believe in the article, how having them in the same place, doing these rather, you know, systemic type of things that you need to do, like you were saying, versus the real healthcare, and how having that in the same place has streamlined and the whole process and allowed you to be more effective in, you know, administering healthcare. Yeah,
I think that's a good point. A lot of my research and my writing has hopefully isn't necessarily critical of the idea of the production line, the idea of like making sure all of our patients get preventive care, you know, like if, you know, everybody should have a cholesterol screen at some point and their blood pressure check. Like,
for sure.
I'm certainly in support of all that. I think that the focus on these very measurable, you know, few things has overtaken the sort of human interaction, trust building, which we're calling the solution shop. So I think what we realized in sort of conceptualizing this paper is that it's hard to separate those two things. You know, you can't be in the middle of an interaction where you're talking about somebody's diabetes, for example, where you're like, okay, I need to make sure that we do a foot exam and refer them for an eye exam and check their sugar levels and check how their medications are doing, and without asking the patient, how are you doing? And if they say, well, I've been dizzy lately, you can't be like, oh, you know, I got all these things to get through.
That doesn't fit the form, man.
Exactly.
That doesn't fit.
I have all these things to get through. I don't have time for that. So you have to
get in the box.
Exactly. So I think that's what happens. Is I've experienced that myself in the quick 15-minute visits where you're sort of by yourself. You're like getting through all of these things, and then the patient's like, I've been dizzy, and you're like, ugh, you know. Do I have time for that? I was going through this and totally. And like, which is sad. It's sad because like, what's more important than addressing a patient need? You know, like
exactly.
It's more important than everything else I'm talking about.
Exactly.
But like
exactly,
the people who are holding me accountable, and this gets back to this whole accountability, can't measure whether I made a good diagnosis on their dizzy spell. You know, that, you know what, I think this is dehydration, or I think you actually might have, you know, something called BPPV, which is like benign vertigo. Whether I make a good diagnosis there, nobody is measuring that, but they are measuring whether or not that patient got their foot exam or their eye exam. So you can see why we as doctors are like making sure we do the production line at the expense of the solution shop. So
totally.
I think the answer is, how do you design? And when, you know, I've been working a lot of team-based models where I had, you know, another person in the room with me and we're able to do both, you know. So
a medical assistant.
A medical assistant was like sort of scribing with me, and that I think you listened to my other podcast.
Yeah, what was the term you used for the medical? There was a
care team coordinator.
Care team coordinators,
yeah.
CTC. That's right, okay.
So
those are critical.
Those are critical. And
those
so
people.
It's in a model where you're seeing, you know, 15-minute visits. I found that I'm able to do my 15 minutes if I'm working with somebody in this model I had two CTCs, so they would go in the room with a patient and they would build rapport. They would hopefully know them from a prior visit too.
Right.
So they build relationships and they would build rapport, build up an agenda, take care of some of the agenda items, like some of the production line items, like colon cancer screening. You can get a colonoscopy or you can give your stool and check it for blood microscopically. Well, they'll just do that. They'll just order the referral to the gastroenterologist or the stool test. And then that doesn't need me, and then I come in to help address the disease spell, and the foot exam, it's already ready and I just do the foot exam really quickly. So having two people and they're in the room typing. And so in that model where you have 15 minutes, that's a way that you can do both, as good as you can. And then I feel like my patients got eye contact the whole time from me. I actually could pick up on nonverbal
as
cues.
Opposed to
typing the whole time. In my current practice, because I have, a smaller patient load and I have more time, I don't have this model, but, I think that there could be room for it in the direct primary care space where the patient has a care coordinator and a doctor that they know really well and that they can lean on for different things, so. But I haven't sort of gotten that far in deciding. For example, if a patient, I speak Spanish, but I'm not a native speaker, and I don't speak perfectly. But if you have a care team coordinator who is a native Spanish speaker, and you have somebody who speaks only Spanish, it might be more comforting to them to be able to speak more naturally and have a care coordinator present throughout the whole encounter, that sort of thing. So we'll see where that goes. But I think you either have to have the time and the space, like I have in my direct primary care practice, to do the solution shop and the production line because you have more time, or if you're in a more time constrained model, then you have to have two people. Yeah. So that was basically the concept. But honestly, writing that article and sending it to one of my friends who does direct primary care, and he's like, you should do direct primary care. That was probably one of the things that was like, you know what, I think I'm going to do it.
When did you write this article?
2022. I think it got published midsummer 2022, and I decided around then to start moving in the direction of I started at that point learning more. My initial sort of foray into moving in this direction was just learning. I went to a conference, I read about it, I listened to podcasts, and
I hear that can be very helpful.
I love podcasts.
Yeah, me too.
So yeah.
Oh, but it's such a daunting thing to think about.
Yeah.
I mean, to be an entrepreneur is a whole nother level of endeavor that it's scary, especially when you're, providing for a family. You've got a family. You've got 3 kids, did you say?
3 kids.
3. How old are your kids?
My daughter turned 12 yesterday.
Okay.
12 on 12/12. Okay. Special day.
Good luck
and
with
then
that.
I have a 9-year-old and a 6-year-old.
Oh, so you got your hands full, and you are you've got to, you can't mess this up. You're kind of playing a critical role.
Exactly.
So you need a team around you that cares about you and that is, championing you to be successful for sure. Yeah. And so about how many patients do you have right now?
I have 15 members who are signed up, which is good. I've seen I think that it's good from my standpoint. I probably started in August with, I saw a few people because people didn't know what this was. I was seeing some patients for urgent care. So I saw some people who needed to be seen that day, weren't interested in the model or and they were sort of transiently in Evanston. So somebody was visiting a friend and they needed to be seen. So things like that. So I really only had 1 member in August and then 1 or 2 more in September. And so it's starting to pick up more lately.
Terrific. And how do people find out about your clinic and you?
They could. I'm on social media. I was never used to be on social media, but we have Instagram, Facebook, LinkedIn.
How do they find you? Just look for your name?
They could Google Bridge Direct Care.
Bridge Direct Care, all one word.
It's
.com.
it's bridgedirectcare.com, or they could Google Bridge Direct Care, separate words, and they should be able to find bridge, like a bridge. The reason the word, I could tell why we chose the word bridge, but and then they could Google my name, Jeff Panzer. They can go to our website. There's a ton of information there.
Panzer, right?
Panzer.
Right. And how could people find out more about direct primary care? Is there a particular source of information that you would recommend people learn about this model?
That is a good question. So on my website, there's a tab that says news, and there's I've pulled a few clips. There's actually a PBS special on my website that shows a model in Wisconsin. I think that's it's like an 8-minute segment. On my website, there's also a 3-minute sort of cartoon clip about what direct primary care is.
Oh, great.
I think those are two good ones. I'm not familiar. There's certainly websites to help us doctors make the transition, but for patients, I'm not familiar if there's an actual website that is purely educational for patients. There are websites. There's a website called the DPC Frontier that has a mapper on it.
Okay.
Or you can look for DPC mapper, and you could find the direct primary care practices in your area.
Oh, that's terrific.
And so I will say, you asked about my numbers and my startup, being, as far as I know, there are definitely concierge practices in the area. I don't know of other direct primary care practices in Skokie, Evanston, in this area.
Okay.
I have friends and colleagues who have started in other states where they have more direct primary care, and it's actually a lot easier to start because people are familiar. So I'm out there. Every patient that joins is pretty much learning about this concept afresh. So
it's less familiar in Illinois than in other states. Where is it more familiar? What other states?
I think it's probably regional in other states, but I know like Colorado, Washington State. There are certain states that I mean, this is more anecdotal. I don't have the exact numbers, but certain states and certain geographical regions, starting a practice, it can be easier to build a practice because there's already sort of a precedent, and people are already, shifting from health insurance to using a health share, for example, which pairs really well with a DPC.
Interesting. And so there are certain like rules and laws and regulations from state to state make it easier to start a direct primary care practice in certain states versus others that you might know of?
There's a lot of legislation around what's nice about direct primary care is it's bipartisan. Like nationally, gets support on both sides of the aisle.
Interesting.
In a lot of ways, because it's a decrease on bureaucracy. It's basically like, and so there's bipartisan support. Some states have certain laws that make basically you can be a direct primary care in all 50 states. I think there probably are direct primary cares in all 50 states. Last I heard there was 49, but I think North Dakota now has one. I don't know.
I'm really curious to, if I investigated, I wonder what health insurance companies are doing to inhibit DPCs. I'm curious. Have you come across any static or friction in terms of things they're doing to try to thwart doctors from starting these type of practices or making it difficult for them in some way?
Yeah, that's a good question. I think that on the national level, the direct primary care is or in all the states that have laws around direct primary care are basically to say that direct primary care is not insurance, because if it is considered insurance, then it's regulated in a certain way. And direct primary care, people are paying you a monthly fee, but it's not insurance. You're not insuring them if they go to a hospital. It's not doing all of the things that insurance does. So the states that have enacted laws protecting direct primary care, I think, I'm not an expert here.
Sure.
There's a DPC doctor / lawyer named Phil Eskew who created the DPC Frontier, which is a good resource. And I've listened to his podcast where he talks about some of the laws around it. But anyway, some states don't have laws, and I think Illinois is in this case that. So there always could be a law that could make it harder for direct primary care.
That's what I'm wondering.
And
Because, you know, the relationship between politicians and corporate America, unfortunately, is a problem. So
I mean, yeah, and I certainly hope. Like I've heard that the DPC movement is not anti-insurance. It's just more like insurance makes sense for things that you don't happen that much and you don't want to happen, but for primary preventive, you know, the everyday care that we can do at direct primary care, it's probably paid for in a different way. And, you know, and that's not
although I think insurance company executives might disagree with your perspective that it's, but I mean, you know, cause that's going to cut into their profits to some degree. I mean, obviously it's a much better system, clearly. But what I'm also looking at is like, you're now creating a structure in your clinic to incentivize real care and bring out the humaneness in people, both the patient and the doctor. And insurance companies will see that as, you know, if it grows, if it really continues to grow. And, you know, in terms of like analyzing what percentage of people go to direct primary cares versus, you know, not care doctors rather. And so that'll be something to look at and something, you know, all direct primary care doctors should be cognizant of. And also it'd be interesting to look at moving forward, what politicians are embracing this model for real, because they might have a problem raising money from these particular people. I mean, that's true. I mean, you cannot get away from the profit motive here. And so that explains a lot. But the bottom line is you're doing it. Yeah. And other people are doing that, and it's been around for over a decade. Did you say?
Yeah,
about 15 years. Did you say?
I would say 10 to 15 years, depending on how official it was. But yeah, there. And one comment I'll make about the insurance companies is, you know, direct primary care. I do. If a patient asks me, "Oh, I'm going to do direct primary care. Do I need insurance?" I would say yes. I encourage people to have coverage for because direct primary care will cover it's always often quoted 80 to 90% of your healthcare needs. You know, if you have a chronic disease that you need to see a specialist for, you know, like that's outside of us as direct primary care.
Exactly.
You know, if you broke your arm, you'd need to see an orthopedic surgeon, for example. And so, so, you know, I definitely, but I do have patients who don't have insurance, you know, and I'm more than happy to see them. You know, I told you my history of working in Africa and working with underserved populations. So in some ways I have some uninsured patients. I have some patients who have like good employer-based insurance, but they're looking for better primary care. And then I have some people who are, you know, have very high deductible plans that make it really hard to get healthcare, and so they're coming to me and they're like, "Oh, this is a perfect fit. I could, you know, get good primary care, and then I have insurance for catastrophe, but it's really hard for me to use that because of the high deductible." You know?
It seems like there should be like some nationalized, you know, I'm just speaking off the top of my head, like a national health insurance plan that, you know, takes care of catastrophic and some other stuff, and then you could go to a direct primary care and pay out of pocket for some hybrid in that way. I mean, there's so much that could be innovated because our current system is so like horrible in so many ways, and now you're providing this model that when we first met, I mean, it just blew me away. I never heard about this. Never. Do most people that you encounter know about this healthcare model just randomly in general in your life? I mean, I know you walk in the circles of the medical community, obviously, but
most people that I talk to, I would say the majority of people don't know what this is.
Yeah.
Which makes my job of, you know, it's interesting. I go to chamber events and I'm meeting people. Chamber of Commerce events. And I'm not just talking about my business, which is really like, you know, my services. I'm sort of myself.
Of course.
But I'm also talking about this new. So it's sort of a double thing. It's like, it's not like I'm like, hey, I started a practice and, you know, it's like I'm started this practice that is a very different way and special way and you know, innovative way to provide healthcare. So it's a sort of a double, you know, So yeah, that is. And my father-in-law said that when I started, he's like, you're going to have to be educating a lot of people about what this is and why it's different.
Totally.
You know?
I mean, I remember we were about to leave the event and I just introduced myself to you. And then next thing I know, my wife was like, dang, he's really involved in this conversation.
Yeah.
And I just, it's like, oh my gosh, this is great, because healthcare is so important to me in so many ways. I mean, there's no way around the fact that people are going to need to interact with the healthcare system at some point, no matter how healthy you think you are, how well you eat, or you work out, or whatever. So, like, life has a tendency to put you on your butt every now and again, and you're going to have to deal with it. And you're going to you want to go to a system and interact with a professional in this field that gives a crap about you, that gives a damn, and is well versed in you.
Yeah.
And everything you've spoken to is so inspiring. I'm so happy that you are here on the show to talk about this. And I was just wondering, before we wrap up, is there anything in your practice, now that you're, it's so new, it's only months old, that you realize, like, we got to do that better, or we could, like, is it evolving as you're going in the moment?
Yeah, it is, and that's one of the things that I've been appreciating about starting slow, is that of course, we technologically I have an electronic medical record that is also a communication platform and a billing platform. It sort of does all three, but the communication piece of it had some challenges, so I ended up adding a new technology that is the secure text messaging app / phone line that I mentioned.
That's great.
So just things that you realize, oh, well, that didn't work as well as I thought. Let's pivot. And so there's things like that all the time. So my colleague who works with me as our care coordinator, she's also an office manager. When there's two of you, you do everything between the two of you. And she's just working with me part-time, but she's phenomenal. And every time we meet, we're working on, improving. We're taking care of the patients that we have, but also improving the systems the processes and the systems. And just for example, when a patient signs up and then they schedule their first visit, that whole process from beginning to end, we're continually making it better. And the forms that patients fill out, this is the nice thing about having your own practice. You're not sort of told, here's the form that a patient fills out. Like, I want to make it fit the patient and my needs in terms of gathering information. So you constantly make it better.
Totally.
I
remember you getting some of these ridiculous forms, like, are you depressed? No. Why am I even answering this? Why are you asking me? I'm not I'm not coming to you for this. I don't know. I'm like lit up. I don't. Just the fact that question can impose a certain feeling, and it's just so just gets in the way. Remove it. This must be so freeing for you, yet daunting to some degree to start it. But you're in it. You're flowing. You're moving.
Yeah.
God bless you. I wish you all the best. Seriously, I really mean it. Is there anything that we should know, or any other thoughts that you'd like to share with our audience before we wrap up? And by the way, we'll be putting any links that you want us to put in the show notes. We will put them in. Perfect. And I'll confer with you after the fact about that. But if there's any other thoughts that you'd like to convey, please.
Yeah, one, just thank you so much for having me. It's been fun.
Pleasure.
It's as you can tell, talking about these topics are fun for me and something I think a lot about, and I'm happy to talk about. And I think that part of the reason that I'm excited about direct primary care is that the system isn't working well for doctors and nurses and care team members and patients alike. It's not working for the people providing care, and it's not working for the people who are receiving care, and I'm
in the traditional model.
In the traditional model. So I think what I'm excited about with direct primary care is it's really different. It's forward thinking and in some ways going back to a time where we had relationship with doctors. So it's innovative in a unique way, because you're sort of going back to a time where some people, not everybody, had access to, a doctor in the 1980s and 1990s. But for those who did, that sort of more casual, like, acquaintance that you have with a doctor that my dad had with his patients and his patients had with him, where they actually cared about each other. I think that we're going, this movement is going backwards to that sort of relationship, valued time where we valued relationships, and going forwards where it's tech enabled. It's meeting people where they're at this day and age. You don't need to go in person for a visit. And so it's really exciting. And I think, I guess I would encourage people who, the question I get all the time is like, do you take insurance? I think I'm trying to flip that on its head and say, we don't work for insurance companies, and insurance companies don't drive the care that we provide. And so figuring out how to put less money into insurance, and then people can afford the direct primary care. And then hopefully someday the government subsidies through Medicaid and whatnot will pay for direct primary care too, so everybody can have a personal doctor and care team like you can get with direct primary care.
Amen. Thank you for being here.
Yeah.
Awesome. Thank you for tuning into the show. If you enjoy this podcast, make sure to subscribe to hear more compelling shows on Rhythm of Life, and keep an eye out for our upcoming series of how we as a society oftentimes incentivize all the wrong behavior here in the United States. We see this in the healthcare industry, in the media, and in our educational systems, to name a few of the fields we will be covering. And this is one of the interviews we will be drawing upon for this series. If you have a moment, please leave a rating and review so more people can hear about us, and share about Rhythm of Life on social media, and like us on Facebook. Thanks for listening. I'm Steve Ordower.
This has been a Rhythm and Light production.